Hello.
Hey, Adam.
Hello.
Hey there.
Hello. Do you say your name Jaffer?
Yes, it's Jaffer.
Jaffer, great.
Perfect. I know we're probably going to have Aaron join us from our team as well.
Great.
Greetings, everyone.
Jaffer, while we're waiting, can I ask you do you know if Aunt Bertha is active at all in New Hampshire? Has it been picked up by any groups there?
Yes, we do have customers and payers in New Hampshire.
I'm curious which customers. I just left New Hampshire and Aunt Bertha had been a product that we had considered. And I was
Gotcha. You say we. Were you a prospect?
one of the district projects, yes.
Oh, one of the
It was
district projects.
statewide, and then I don't think anything came of it because of the legislature.
Gotcha. Yep. We actually have probably 30 or 40 customers all in New England, many of which serve New Hampshire, some payers directly in New Hampshire. Happy to share some more information there. But do we have everybody from your side?
I believe we do, but Amanda is the keeper of attendance. Do you know, Amanda, anybody else RSVP?
Yeah, it was Jennifer, and I'm just letting her in now.
Oh, Jennifer. Okay, great.
Great.
And
I
are
haven't
all
seen
of
the
the
name Eric John in a while.
you guys go way back?
Yeah. Hi, Aaron. How are you?
Good to reconnect. I saw your name and I'm like, that has to be the same person.
Yep. It's me. It's still at it.
Awesome. That's great.
Glad to see you are as well.
Yeah, absolutely.
All right. Anybody else from my Aunt Bertha coming?
Just
the
Jaffer.
two of us.
Okay, that's great. So thank you very, very much for agreeing to the interview. We appreciate it, and we hear, excuse me, we hear wonderful things about the work you're doing, and look forward to hearing some more details of it. Daniel, do you want to say hi for the group or?
So just briefly, one of the co-founders, and appreciate the opportunity to get your perspective on this work as we put together a national scan that I'm sure Adam and Amanda have talked to you about, and really help inform the industry about how to really move forward on consent to really improve care coordination and all of the interoperability and data sharing kind of stuff that I know that you guys are really committed to. So I won't take up any more time than that. So pass it right along.
Great. So let's just start with very short introductions, please, so everybody gets a sense of who is on the call. If we could, let's start with our guests. Jaffer, you want to go first, and then Aaron can fill in, and we'll go from there.
Yeah, and I'll keep it very brief. Jaffer Trace, I serve as a COO for Aunt Bertha, 25 years in healthcare and social care work, including a big background in electronic health records, and have been playing the role serving on several policy-related committees and national work groups on this topic. Aaron?
Aaron Gray, I'm the founder of Aunt Bertha. We've been around for 11 years this month. And prior to that, worked in government for 6 years, 4 years with as a contractor to the Texas Health and Human Services Commission, working on simplifying the eligibility process for people getting enrolled in public benefits like Medicaid, SNAP, TANF, and Children's Health Insurance Program.
Terrific. And I'll just say that from the steward side, what you're going to hear is a small group of people who are working with us on our consent project and or our project Unify, of which the consent project is a part. But they are all, as you'll hear when they ID themselves, independent of stewards, and they've joined us for this work. And with that, Chris, you want to say hi?
Sure. So I'm a health law attorney, and I most recently worked in New Hampshire on the district project, and our project was all about greater integration. And the part of New Hampshire I lived in was particularly focused on cracking the nut of getting clinical and non-clinical entities to be able to share client information, which I know is one of the things that Aunt Bertha does. So.
Okay, looking down my screen, Jennifer.
Hi, I'm Jennifer Hall. I'm the program manager for the state of Colorado, overseeing our interoperability work.
Amanda?
Hi, yes, Amanda, Stewards Change Consultant. Work closely with Adam and Daniel and Project Unify.
Great. Bill?
I'm Bill Kowalski. I currently work with FEI Systems, but spent over 25 years in government running Department of Human Services programs.
Brian?
Hi, I'm Brian Hanspicker. I'm a technical project leader for Project Unify, co-chair of the consent governance and consent technology working groups, amongst a couple of others. Full disclosure, I'm also Chief Technology Officer for Open City Labs.
And last but not least, Eric.
Hi, Eric Yan, Alexandria Consulting. Thanks.
Oh, that was very brief. Okay, and I am Adam Pertman. I'm also a senior consultant to Stewards of Change. I work closely with Daniel and others on most of, if not all of our projects. And I am leading the effort on the scan work, though not Project Unify, which is more in Brian and Eric's bailiwick as the technical geniuses. I don't know what the hell they're talking about half the time, but fortunately I don't need to. With that, I'm going to.
Sometimes we don't either.
How to scare everybody. So I'm going to turn off my video. And I'm going to be taking notes, so I don't want to be distracted or distracting. So give me just 10 seconds to call up the file. And you got I think from Amanda sent you a document with the general questions that we're going to ask. What I'll say is that you can answer them any way you want. In other words, we fully the way we shaped those questions was to have apples to apples. So across all the interviews we're doing, we want the questions to be similar, if not the same. But we recognize that the people we're interviewing work for very different organizations. So your answer can and should obviously be go in whatever direction you think is appropriate for Aunt Bertha. Cool.
Yeah, Adam, that sounds good. And what I might suggest, actually, since we have the time, is if we want to address the first question, but then give us a chance to do a little bit of a show and tell.
Oh, absolutely.
Address the bigger picture issues, and then I think we can come back to some of those questions as they relate. It might really provide the context that you're hoping to achieve in the
That's terrific. We welcome that. And I'll also add that if we don't get to anything in the hour we've allotted, no sweat. I mean, unless you have a real time constraint, we have a few weeks, so we can send you subsequent questions to answer in writing or give you another call or whatever. So we're not stressed out about the time. And so take it however, in whatever direction you think is appropriate.
Wonderful.
Okay.
Wonderful.
Great. So do you want to do the show and tell as a setup, and then we'll
Sure.
get to questions? Or
yeah, I'll do that. If you want to give me ability to screen share.
Yeah, Amanda, give it away.
All right.
Okay,
Wonderful.
I think we got it.
Yep, you sure did. And I will just breeze through a very little bit of background to kind of set the stage. I think.
Are you going to tell us first who Aunt Bertha is?
Sure. So actually, Aaron, do you want to spend 60 seconds to tell the story?
Well, it's funny because when I started the company, I was I worked in public policy, but I certainly was not then and am not now a marketer. But I worked for Uncle Sam for 6 years, 6 years in government, and
Uncle Sam and Bertha.
Yeah, and it was a play on words there, but while I was helping the state of Texas process, reform the way that people apply for public benefits, it happened during the financial crisis, and which meant that the demand for food stamps quadrupled in a 4-month period. And when you're looking at a state the size of Texas, it was a shock. There certainly wasn't enough state employees to be able to even process those applications. And so one of my jobs was managing a team that oversaw the QA department of the call center. And so I flew up to Midland, Texas, put on a headset and listened to calls all day just to see what technology they were using and hear what was going on. It was during the thick of the financial crisis. And there was a woman from Houston that shared her story, and she couldn't, she filled out all her paperwork correctly the day after she received it in order to renew her food stamp application. And, but the state didn't have enough employees to do the state mandated interview. And so it meant that her appointment was pre-scheduled several weeks after her food stamps were going to expire. And so for me, I realized that, at least as it relates to technology, when the safety net falls apart, what happens? And so you take that and sort of the friendly relative that we all go to when we're struggling, and that's where we landed. The domain name was available and it was $13. And that's the story. We're actually in the middle of a change. We're changing our name to Find Help, which is something that we tested out during COVID and is a little bit more intuitive. But our company name is basically the same, but our product is organizing under Find Help. We also run findhelp.org, which is our free search that's out there.
When does that change so we know what to use for publication?
Oh gosh, depending on when you're publishing, it's in the next couple of months. So we can coordinate on that. There's a big timeline I need to look at. I don't have the exact date, but there's consultants helping us out with new logos and all those other things.
Okay.
Yeah.
All right. Thank you for that. Take it away.
Yeah, absolutely. So a couple slides, and then I'll jump right into kind of consent and privacy. Our vision, fairly straightforward, but grand. It's not only helping people find the right services and apply for those services, but have the dignity of a response. Something else that's very important that impacts consent is the ability to do self-service navigation, and very importantly, have private referrals. And many vendors skip over or ignore the self-navigation or private referral notion, where that information remains private until they choose to share it. So self-service is important. And then of course, tracking the search referral response outcome data, and then importantly, who has access to that outcome data and when. This is just a glimpse of the nationwide network, example of search activity on the top right, a heat map of that happening all over the country, the number of users, the number of program locations that are available in the open network, and then the number of those that have actually claimed their program status in Aunt Bertha and are using some degree of our free tools for the nonprofit suite of applications. So just a quick background there. One thing I'll just remind the group is, since we have folks from many different companies and backgrounds, let's consider all this information confidential. If there are specific things that you'd like to include in your summary, of course, we can collaborate on any permission for commentary or data. This is a real view of the volume of monthly referrals through the Aunt Bertha network, just shy of 100,000 on any given month right now. And we believe this is larger than any other or rather all other social referral networks combined right now. And that speaks to, I think, some of our process related to consent and privacy for how we keep information secure. We can come back to that. An example, of course, on answering one of your first questions around where do we play in our space, it is across many sectors or all sectors, from self-service to government, cities and counties, many healthcare systems and organizations, 8 of the 10 national plans, many in education, including community colleges and K-12 districts, and then a lot of national networks like the Red Cross, AARP, YMCAs, United Ways, and so forth as customers as well. So we absolutely understand the nuance within a sector in terms of regulation, and then we also understand the nuance across these sectors. And many of our communities, as you know, are facing the opportunity to solve for that today. Importantly, we also have many payer relationships covering almost the entire country. New Hampshire should be covered there with AmeriHealth, but there's quite a bit of chatter and discussion on how these payers get access to their members' information in any given state that they may be served by any of our customers. And that's a topic that we'll address when we talk about permission-based access to information as well. Just a quick glimpse on customers across the nation. Of course, we're almost there with every state. This is going to allow us to be a nationwide EMPI or EMSI, as we call it, where we'll have the capability to give consumers true consumer-directed privacy of their information across the country. And that's going to be very powerful, especially with Congress considering privacy bills, along these lines. Some of you may be familiar with the referral form in Aunt Bertha on the left, and there's referrals and applications and some other functionality. We'll zoom in on this in just a bit, but you'll notice the confirm consent section on every referral. And this is either a verbal consent, express consent reminder to the individual that their information is being shared specifically with the agency or nonprofit that is serving them. And then, of course, the nonprofit agencies receive the individual's preferred contact method, preferred language, and other details about that referral. Our customers follow the regulation in their space for what type of information they choose to transmit through the system with that consent to the receiving nonprofit or CBO. And so healthcare entities can share PHI because the platform is high trust, certified and compliant. But of course, education organizations may not share student record information according to FERPA. We allow our customers to follow their rules with the appropriate consent. Another concept I just wanted to share before we dive into our specific consent model is the notion of nonprofits using a system of record that best meets their needs. And all of those on the left that I've spoken with have agreed that we should have interoperability in our space that also keeps track of the consent. And at the Gravity project discussions, we've discussed the importance of including a consent fire resource that captures that indication that a consent has been captured per referral. And that's a really important distinction that these vendors on the left are aligned with. You'll notice there's one particular vendor that's not there, and they have not agreed to a per referral consent process in this space. But this notion of nonprofit choice means that if the nonprofit's using Salesforce, we should pass the referral into that system of record. If they're using Healthy Planet Link, we should pass the referral into that system of record. We'll talk in just a little bit about the implications of then how that data gets further shared from a non-covered entity to another non-covered entity, but this is an important distinction for our work today. That's a distinction from a government or a HHS department essentially mandating one tool that may have issues in their privacy policy or in their consent model that don't meet the needs of the state, the constituents, or of the nonprofits who are really providing this service. And you mentioned New Hampshire in the very beginning. We'll touch on that in some of the legislation we saw around the issue with kind of a government mandate. Just to show you a real live case, this is where in Colorado and also in Texas, we already have this interoperability live where referrals go into Salesforce as a system of record for nonprofits to manage their workflow in a way that they respect their privacy, their additional consents, and process for information capture. We've learned a lot from our Epic customer base. This is just a quick list of those that we work with today and growing, but they're very cognizant of the compliance issues around consent in the healthcare space. And we've worked on a significant integration with our Epic customers as well to ensure that we're still able to capture consent, in the workflow. And we've advised Epic and Cerner and others on making sure they include a per referral consent option in their implementation of deeper integration. So to quickly, pivot to the root, question here, Aunt Bertha has the position that the process of capturing that consent should be on a per referral basis. And what's important about that is every time an individual is seeking assistance, there might be a different situation at hand. Perhaps I have a daughter with an opioid addiction, Or perhaps I'm self-navigating and I want to find a domestic violence hotline. Or perhaps I'm talking with my social worker and I'm looking for a utility assistance program. Each time, I should be reminded that my information is being shared with that particular agency. And each time, there might be slightly different rules around what happens when that information is shared. By it being a per referral consent process, but not intrusive to the individual, we can make sure that they know what's going to happen with their private demographic information or additional information that that navigator or helper may share. This allows us to keep track of which organizations can then see that particular person's private information and not overshare it to other entities that might be in the network, but have no relationship with that particular person for care coordination. And we'll look at an example of that. On the right-hand side, there are vendors out there that have followed what we call an all-in consent model. And I'm sure you folks are familiar with the informed consent documents of some other vendors, where they essentially say, and I'll show you one, that by an individual signing this consent, it's the only way for them to get a referral in that platform. But they have to sign away ownership of their medical, behavioral, financial, and social information, no matter who shared it with that navigator about that individual. And the vendor also controls who can look them up in the system and what information other people see about them. And at the end of the day, not only do some of the most vulnerable people not necessarily understand the implications of signing away all that information and access to it, but it has the potential to cause significant harm. Harm like no longer being eligible for certain government benefits because they shared something privately with their social worker, or the stigma surrounding someone at a local church food pantry, looking them up in a small town and realizing that their family has significant other issues, and that could even be a relative. So there's a lot of implications for this all-in consent process. So by having a permission-based model, we can keep track of who should have access to this particular private information. So we differentiate when a referral is made. There's self-navigated referrals that are private, and that's only between the individual and the agency that they're self-navigating to. Nonprofit-initiated referrals, and these are referrals from one nonprofit perhaps to another that the seeker or the person in need is also privy to. And then staff or customer-generated referrals, where a navigator or a helper and their entire organization have access to that referral to help the individual, as does the CBO and that person. So this allows us to keep track of who should have access to that information. So some of our values are that private self-referrals remain private unless the seeker chooses to share it, and that the seeker actually owns their referral history so that no matter where they go across the country, they can share their private information and still get help.
So forgive me for
Yeah.
interrupting. Seekers are the patients, are the individuals?
Exactly. So the seeker is the
Seeker
person.
sounds like something else. Okay, got it.
Yes. The seeker is the person in need, resident, constituent, patient. We just normalize around that.
Right. Seeking assistance or seeking a program or project.
Precisely.
Yeah. Okay.
Yep. Customers, of course, let's just call it Mayo Clinic as an example. They absolutely need access to referrals that they initiate across their system. They have different teams that help people, and so they need that access. And they also own the data they put into the system, like their care coordination notes, their assessment questions, and so forth. And then importantly, nonprofits need access to referrals sent to them, of course, to do their own intake and management, but they also own the data they put in their system, like outcome documentation. That's not automatically signed over to a vendor just to serve one industry. There's the education space and the nonprofit space, and we can't just serve one industry in ensuring that people can have their documentation about assistance shared with those that may help them. So it's important that the nonprofit controls that outcome documentation. And importantly, nonprofits don't just look up anyone in the network. They don't see unrelated referral history unless it's been shared through appropriate means. And those appropriate means we'll get into. Those could be BAA relationships. They could be partnerships that they have with a particular network and so forth. But they need to be defined. One situation that came up on a webinar in Florida recently, actually. A couple of nonprofits were upset that some CBOs that were using the Unitas network were able to look up anyone in the network, download the list of people, and then spam them with marketing messages about the services that that nonprofit offered. And that goes in direct violation of this value or principle, which is that the nonprofit shouldn't be looking up people they have no coordination relationship with. So we covered this, but we all go through tough moments, and we should, adhere to these values. And I mentioned these examples. I don't want a food bank to see my substance abuse personal referral as an individual, but maybe I'm a CBO and I share referrals with another CBO down the road when they're my sister food pantry, and we have an agreement to be able to do that. And we make sure that the patients or seekers know about that relationship when they come. And then, of course, customers. They have relationships too. A great example of customer relationships are Virtua, Cooper, and Jefferson Health, where they all participate in the Accountable Health Community's grant work, which I'm sure you folks are quite familiar with. And the Camden Coalition acts as the navigators on behalf of all of those cohorts in the AHC model. We respect that coalition, meaning those three entities can see each other's referrals as staff because they're in a coordinated relationship as part of that initiative or project. So we absolutely can respect what we call coalition sharing of information. So when we think about consent, of course, there's medical consent, which protects clinical staff from liability. We have what's called the express consent, which makes sure with every referral, we're protecting the seeker and keeping track of the right relationships for who should see their information. A lot of other vendors use an informed consent that gives them rights to own the data, to protect that vendor from liability if they share it, and to share that data with their own discretion, meaning allowing any CBO on their network to look that person up without the seeker knowing the transparency or having control over it, which the ONC has said is really important in this space to have that consumer-directed approach. So I mentioned our consent language, and of course, this is slightly different if you're self-navigating versus if you're a helper. And I mentioned the Camden Coalition as an example of respecting existing data sharing agreements. This doesn't only need to be between healthcare entities. This is where we can respect agreements between CBOs, healthcare, even government agencies, especially within a certain region where they have a coordinated project to help a specific cohort of the community. So in this example, if Cooper did a referral for an individual for moving support, Jefferson made a referral for the food pantry, and Virtua made a referral for legal assistance, all three referrals are viewable, but they're viewable because it's appropriate, because of the coordinated relationship, not just because these health systems happen to be in the same region. This, I think, is actually a really important slide. This is the feedback that we heard from our 300-400 customers, which is we need to provide transparency for an individual into who has access to their private referral information. And so we built functionality currently called seeker sharing, where an individual could log in and actually see who has access across the system to their private referrals. So if I lived in California and I wanted Sutter and Stanford to currently see my private referral history, I could make sure that they have that access. But if I move to Massachusetts and I no longer want them or those social workers to see that history, and I really want to share with Mass General Brigham, I can also control who has access to my private history. This is really important, and I think is respecting the seeker's dignity in who and how they share information. We also created functionality that allows helpers or navigators at our customer sites to request access to this private referral history. And so now by submitting that request button, it sends a message to the seeker, and they can actually approve that sharing to a specific person, whether that be a navigator or another helper. And then that information is on the chart so that the remaining history can be viewed by that particular helper. And last but not least, of course, there are going to be special waiver programs like 1115 waivers, 1118 waivers, where there might be agencies or nonprofits that are part of the health system or payers initiative and very closely aligned on solving specific problems. they can be provisioned onto the platform to have the appropriate level of access to see the full history, given the context of how they're serving the individual with in lieu of services or other specific supports. Like we support BACO's initiative and Mass Health's initiative in Massachusetts for flex services, which we've done, for the last year. So absolutely, we can manage provisioned coordination as well. So we've taken the harder road. We've taken the longer road, which is respect data sharing agreements by our customers through coalition sharing, respect the dignity of the seeker through seeker sharing and control over the private referral history. And when there are special projects, enabling the functionality for provisioning nonprofits or agencies directly on to the customer's instance to see the full history. But these three really respect the person in need as much as possible with who has access to their referral history. And this is all managed because we know the consent for each program each time. I promised I would share a couple other examples. I'm sure you've seen these. I think you've probably worked to support certain regions that have used both of these networks before. But on the left, it's very transparent that the consent is saying your information might be shared within or outside of the platform and the network. But to receive the referral, you have to sign. The 2-on-1 CIE example indicates financial, behavioral, and medical data may be shared and redisclosed from non-covered to non-covered and is no longer protected. If you opt out of these, you cannot receive a referral through these networks. And I think this is what the state of New Hampshire in particular took significant issue with. And so, yes, there was bipartisan support in New Hampshire, and the governor signed a bill, very rarely actually calling out a specific vendor for their violation of some existing privacy laws in the state of New Hampshire. And so what's specifically called out here is the need to have a per referral consent and only appropriate access to referrals by the agency that they're a party to. And this is not supported currently by that vendor. And so there's been some specific language here and some specific criticism. And then I think you folks are probably privy to the recent HHS RFI related to HIPAA and the recommendation to make it easier to support care coordination. They didn't specifically call out social care, but certainly it would fall under the modification of these rules. Zooming in a little bit, and the notion of removing professional judgment when sharing private social care information would cause some consternation. So we think good faith is perhaps not enough. We think that professional judgment is very important as a standard when sharing social care information. And we believe that PHI should not be disclosed to an unidentifiable or unspecified network without transparency to the person in need, so they know who has access to their most sensitive information. And this is how it works in even healthcare today, even in the Care Everywhere model, where you know exactly what organizations are privy to your information. So this was some of our feedback to HHS, on the new potential rules. I'll pause there. That's a lot of info, hopefully helpful. There's more we could share on kind of standards and interoperability related to consent. But let me ask, was that helpful to get a lay of the land, and does it answer some of the questions?
Yes. Speaking for myself, Adam. Others? And I'll add to that, anybody got any questions or want any clarifications or elaborations?
So for me, the questions are going to be kind of the level about, and I should say that I was not involved in any decisions in New Hampshire about what vendor to use. So just to be clarified with that. And so my questions are really more like the next level of it. Like, how did you technically handle those permissions? Like how, and if you could give or something, but just show us, how did you build into the system the controls or handlers or whatever, so that more generally, not everybody can have access to things, but then also more specifically, part 2, data. I'm curious to know how you handled that.
Yep, absolutely. So what's important, and I don't think I have this is a good example of showing navigation history for an individual. But when, let's use Massachusetts as an example, because we've got, many customers there. When Boston Medical Center generates a particular referral, the helper or the care navigator, we know that they're associated with Boston Medical Center. And so BMC should have access to it. When they generate that referral to the food pantry, we keep track of who the provisioned users are at the food pantry and who the provisioned users are at BMC in the health system. And so we know specifically that who should see that referral are the provisioned users of those two entities, and that other individuals outside of those two entities should not be able to look up that person's history of that specific referral. So we know who's party to that referral every time one of our customers or a CBO makes a referral. So our system is intelligent enough to keep track of who generated it and who is receiving it. So we know who should have access to it. Our system's also intelligent enough to know if Boston Medical Center and Partners Healthcare are both participating in Flex Services, and the Flex Services user generated an order for medically tailored meals, that those teams that are provisioned for Flex Services should also see that medically tailored meals referral, because they're part of that particular project. So we keep track at a user level of who's provisioned to see what information. And Aaron, feel free to jump in or correct me.
No, I mean, Chris, thanks for the question. I'm going to put my programmer hat on for a second there. And we started there was never a default in model. So we started from literally the referral record has two parties. It has the organization, the organization's ID that's sending the outbound referral. And that could be any one of our customers. Then it also has the organization's ID that's receiving the referral. And so the core of it was that's enough to start with, and then we worked up from there. So it sort of goes to default out. Basically, most users don't have access, and the only users that have access to that referral are the sending organization, essentially the employers of whoever that social worker is, and the nonprofit that received it. And then we built layers on top of that. So I can get into the technical weeds, but you can think of it that way, which is different, from the normal model.
So can I ask a follow-up question? Do you mind?
Of course.
Okay, so when you're talking about building up at that point, is it that the patient, for the self-navigation part of it, at that functionality, the patient can indicate on some kind of a list who else they will allow, to have access, or is that? Because that's been one of the challenges that I've seen.
No, you're asking the exact right question. And Joffrey, if you can just show a referral form, you had a screenshot of it there with our consent on there.
Sure.
So if you start, literally, ABC nonprofit elects to receive referrals. And you can look at our privacy policy and our terms. What we're saying is, the first one I'm going to walk you through is a self-navigated referral. That's the seeker. In that case, there isn't an affiliated social worker that's sending that outbound referral. So in that case, the most granular level through self-service, the seeker is saying, I allow ABC nonprofit to see just the information that's in this referral. Now, this is a simple referral. We have a couple different types of referrals. There's screeners, which has additional questions that nonprofit asks for. So for example, if it's a disability program, maybe they need to know details of your disability. So from our consent perspective, and we can send you our privacy policy, it's very clear that for seeker initiated referrals, literally in the referral record, there is no sending organization, it's blank, because that's a seeker initiated referral. The receiving organization is ABC nonprofit in that case. So that's the most rudimentary referral. If you see that top, it says, who is this for? It says either myself or my family, or I'm referring someone else. So this is a picture of an outbound referral sent by an employee of one of our customers or an employee of a nonprofit. It's the sending organization. And so in this case, let's say it's Boston Medical Center, they send to ABC nonprofit on behalf of Shelley in this case. Well, now in that referral record is the organization of BMC in that example, a hash key that we have, as well as, the hash key for ABC nonprofit. And then of course it's affiliated with Shelley. And so in that case, assuming there's no other agreements, let's say there's no other agreement, coalition sharing agreements in place, then that's Shelley is saying, yeah, I'm okay with ABC nonprofit to get it. And that's our evidence of it right there.
Yeah, that second example is more the type of sharing that we're looking at in this project. It's if I can speak for the project, and correct me if I'm wrong, Adam or Amanda or Daniel. This is we're trying to crack the nut of how to have like some kind of universal consent, right? Or some kind of where there's a data sharing is allowed. And also allows for controls. So for example, if there's information, if the patient has, patients are telling us, right, and the studies show patients want there to be easier data sharing, right, for care coordination purposes or whatever else. So that's the nut that we're trying to crack, is figuring out how can you do consent where big programs are going to be sharing data. That one of the issues is that if you've got Part 2 information in the system, how do you control for that so that only certain people can see it? It sounds like you've navigated that already because you're treating Part 2 information, it sounds like any other kind of category of information where the person's consent can decide that, they can decide specifically, but in a group to group share, well, how do you?
Yeah, so I would, I'm using this terminology just for the purpose of explaining it. So I would decouple consent with what's queryable, just for the purposes of an academic discussion. And so what we're describing here so far in those two use cases, those two examples that I just shared, is the consent to share that content, the fact that Shelley needs services and has this metadata with ABC nonprofit. Now, she can choose to apply essentially for 5 different programs from 5 different nonprofits. That's totally okay. So she's only given consent at this stage to ABC nonprofit to receive it. And of course, to BMC if she's with a caseworker. Now, what's queryable is a different story. And so I just want to take that modular, sort of abstract object a little bit separately. And so the business problem I think you're trying to crack is that, okay, what if we use BMC? What if Partners wants to look up information? What if Partners wants to help Shelley? Or what if, what's another hospital in Boston? I'm just trying to. Beth Israel. Yeah, Joffrey, you might want to take it from here. But I wanted to make sure that you understood that we start with the most restrict permissions possible.
Yeah, and that's intentional. And I think if we think about the person's chart, there's going to be those referrals that organization made for them that people in that organization can see. Then there's going to be the coalition of groups in an industry like healthcare that can see the collective referrals because they're navigating together. But then there's going to be private referrals, and those will remain private until the individual chooses to share that information or gets a request to share that private referral history. And so there's a few tiers there that can be controlled at the appropriate level. And then you mentioned, 42 CFR Part 2 type information. Because of our certification, it is okay for healthcare to share information for the purposes of care coordination. And I've followed up with the Office of Inspector General, and I've followed up with OCR to make sure that our customers are in the right to be able to share that information for the purposes of that referral. And because of our permission basis, and because it is restricted, that information doesn't go anywhere else in our platform unless the individual chooses to share it, which is part of the requirements, of course, for 42. And so far, 100% of our customers' compliance teams have agreed that our model supports appropriate sharing. Now, the exception to that, and this is not about us or any other vendor, or just in general, is that to then redisclose that information by a CBO to another entity, the CBO has to follow a written signature, process or be certified themselves, many of which are not. And so in our terms of use for nonprofits, we remind them that if they do need to disclose this information, they have to follow the appropriate rules to do so. So we've succeeded significantly, at least with respect to between CBO and healthcare, for those purposes.
This is Brian. I have a perhaps more technical question. You've mentioned earlier that that you have referral partners like now POW, Salesforce, Epic. How do you and you mentioned that part of the quid pro quo to being a partner and being able to exchange referrals with each other is that they must embrace your approach to consent. How do you exchange consent, or how do you represent consent assertions that you then presumably exchange with these referral partners?
Yep. So two things, and I'm glad you asked. And I think, do you guys have actually a representative on the Gravity Technical Advisory Committee?
That is me.
Gotcha.
Oh, good.
Great.
I recognize you from Gravity.
Okay, very good, very good. I'm quiet until Ned yells at me to speak up is probably what you've noticed sometimes. So two things. One is if the system agrees with the privacy approach, meaning it's a per referral consent, and then the information is not automatically disclosed or redisclosed, then we're in good shape to be able to share that information. What isn't available as a FHIR resource yet is the actual consent object. And so that's what Bob and team have agreed to implement as part of the initial implementation guide, is that resource object. So for any of these integrations we're developing, our development team is going to have to go back and add the consent object as part of the FHIR resource payload that's going to go over to any of these additional referral partners. So it's not sent yet, but because we're aligned in the policy, we're able to share that particular referral.
You have uttered the magic words, FHIR consent. The associated question is, how do you represent referrals between these folks? At the moment, I suspect you're going to answer whatever Bob DeTurley comes up with.
Good question, but not necessarily. And so okay. I may be able to just kind of run on the fly, actually, and give you a quick example. So there are many vendors, of course, like Epic and Cerner and others who have said, you know what, we're not waiting for the Gravity implementation. So like us, we also created APIs, and we use existing FHIR resources like service request, task, document reference, and others to already transmit referral information in a bidirectional manner. So yes, we want to upgrade, so to speak, to what the Gravity work group is going to publish. But in lieu of that, we have to use a combination of web services and existing FHIR standards today.
Any comments on direct secure messaging?
Direct secure, direct trust, 360X. I think all of these are options, and we'll probably end up using some form of all of them in different parts of the country. There are certain states that are getting funding to really support, some other modalities. I think we'll work with those as well. But I think we'll probably see FHIR becoming, the primary, over the next couple of years.
Wearing a completely different hat that I should be wearing in this particular meeting, you and I probably ought to have a chat sometime in the next month.
Certainly happy to. Yep, just ping us and happy to.
There's good stuff afoot.
Excellent.
All right, so mindful of the time and our not having gotten to any questions yet, which is really fine because you have indeed addressed several of them, but not all of them. And I foresee some written questions coming your way.
Sure.
But I want to give a little airtime to anybody else. Excuse me. Chris and Brian have spoken up, but I want to make sure if I move on, that anybody else, Daniel or anyone else, if you have any questions, please speak now, or I will move on. Okay.
I had two quick questions, I think. I just asked a quick one, Chris. I want you to get your question in here. One is, I can't remember if you said you deal with FERPA, because we're thinking about also situations where, parents are having to authorize sharing of, attendance data, assessment data, those kinds of things, which don't really go to a CPO, they'll go to a state agency or county agency. Same way on probation and court kinds of information, which are outside of their sort of non-fire-based kinds of things at the moment. How do you address those kinds of system kinds of consent requirements, if you do?
Yeah, it's a great question. So we actually have a project internally where we've been collecting a lot of information about proxies, whether that be from our children's hospital customers, from our family navigation customers, really trying to get industry agnostic perspective on what are the age requirements across certain states for social care versus for medical care. There are different ages. We want to be able to distinguish a record for a minor or for a proxy, have a relationship either to a household or to the particular primary navigator, in the family or caretaker, but keep the information distinct and manage access to that information appropriately. So I think we'll probably be releasing more functionality around the proxy use case. But today we differentiate between those users in our system. And we have functionality that's called enforcing identity, so to speak, so that if there happens to be a family member and a child, so to speak, they have distinct records, in our system. And we may know that they're in the same household, but we keep that information distinct. I think we'll probably release more functionality on when it's appropriate for a household member to have access to it.
So you're essentially, if I understand what you're saying, you're essentially focused in on those referral partners at the CBO level between them and state or county or municipal efforts, not necessarily yet between other sectors or domains, what we'd be saying.
No, it would be all domains. I think what I'm describing is this notion of there being a proxy. So whether it be me helping my dad or me helping my child who's a minor, or my aunt, helping me and we're peers, it's a proxy relationship that we need to manage consent for. And only if that proxy has given permission as an adult, or if they're a minor and by default, they're required to by law give permission, that's how we know how to construct access in the platform to that additional data. But we keep the records and information distinct until we know about that particular relationship.
Okay.
Yep, and that's across all sectors.
Dan, you said you had a couple of questions. Anything else, or?
No, that was, I just was curious if you're dealing with sort of guardianship, because education data is critical for social care, and we haven't seen anybody actually doing that at this point in time, especially around attendance data and things like that. So,
Eric, Jan here, quick question. And I think this question would go for all of the systems presenting in this series. How is what each presenter says is happening, how can we audit or know, how can a community know that every rule that is stipulated is actually enforced, is actually, and that historically, how can we go back and see how records were shared internally within the system and externally with other partners? Like, what is the way that a community can know that the rules that they have specified are actually being enforced?
Eric, I'm not quite sure how to answer that. The way we work is from our sales, so just a little bit of education on our business model. We don't go into a community and sell multi-million-dollar piece of software to a government where it's a sort of a big thing. Our customers pay us to join our network. And so our product, for example, ranges anywhere from $5,000 a year for a smaller organization to about $70,000 a year if it's a large hospital system. And
right. So it's a
is
software as a service model, right, Aaron? Is
Yes.
what you're saying. I mean, that's what I assumed you were. I didn't think you were doing otherwise. I think it still applies to the question. I mean, how does a customer, whether they're a tenant in a software as a service or having the whole enchilada, as with other presenters that we'll be seeing or have seen with this series, how, I guess the answer, how would your organization answer that question? I think it's still valid software as a service or hosted platform on behalf of an entity. Either way, it's still, I think the question would still apply.
Eric,
I
are you asking what are the sort of the regulatory structures in place to make sure that everybody's doing what they say they're doing and sharing what they say they're sharing?
How can it be audited by the customer
Yeah.
easily to know what's
Okay.
going on? You know, how is the consent being enforced? How can we see that it's been obtained and that it's actually been enforced in the way that the customer or client or patient specified?
Well, what I can speak to is during our contracting process with each of our customers, we're introduced to their compliance department, who has, in many cases, usually a spreadsheet with about 12 tabs. And we go through a process where we answer all of those questions. Sometimes they just look at our high trust reports and, you know, get to understand it. And then sometimes they lean in and they ask those questions pre-contract process. And hopefully they have a thorough understanding of our rules and how we do it before they buy. We also have a series of reports that allows them to see deep things within our data warehouse. And then lastly, our customers subscribe to a product where they actually have their own segmented version of the data in their own data warehouse, where they look at the ERD, they can run SQL statements themselves. So I don't think we've ever been asked by a customer to sort of audit the permissions model. We certainly would be happy to walk a customer through and sort of show how one might do it, but it's not something that has come up where you know, we have a process for it, you know, if that makes sense.
It does. Thank you.
So
I would just add to that real briefly, if I may. That, I have had customers ask, do we capture that consent with every referral, and is that auditable? Absolutely, it is, and I think that's the important note. I think what they've asked other vendors, even in our presence, is with a one-time, you know, consent, do we then know how nonprofits then share data? And the answer then is not necessarily through their own network. So, for example, is there a penalty today or regulation if a nonprofit using another vendor looks someone up inappropriately because they have access? There's no penalty; it's not illegal, and there's no audit trail, you know, of that with a permission model. Versus in our model, there is at least the record of that access because it was permission to begin with.
So that's
in blanket permission model.
In our model, it's not blanket permission.
No, I'm saying that's where you're saying it's not auditable when the blanket permissions.
Exactly, precisely. When it's a blanket model, and that's what we saw happen in Florida with a CBO telling us on a webinar that, you know, their neighbor CBO looked up, you know, 1,000 people and spammed them. Well, they wouldn't have been able to do that in our model because they didn't have that coordination relationship.
And then also, oh, sorry, Eric, also to answer your question is we have SQL logging, you know, that essentially indexes, you know, all queries in our data warehouse as well. So that's an extra way for us to see who's looking up what.
And Adam, I would say this is the issue that, you know, Jaffer has really, you know, fine-tuned is that's a difference between two vendors, right? But it is a big issue that in terms of who can access the information. From our perspective, I think just to kind of, you know, looking at the time, one of the questions that I have is how do you handle, okay, so 2 questions about revocations. Well, 2 questions. The first one is, how does someone signify that a client or a patient of theirs has revoked consent so that no longer will that information be shared in the system? That's one question. And the other question is, just to confirm that I understand it, it's the community-based organization that has gotten the patient or the client's consent to make the referral to another group that do they get the client's electronic confirmation of their consent in your system some kind of way, or do they have to have, are they affirming that the CBO worker has obtained the consent of the client or patient? How do you, those are two distinct issues, but I'm curious if you can speak to them.
Yeah, and you know, we're right at time, but very briefly in the latter, it's stored electronically, but it doesn't need to be a signature. Some CBOs, depending upon the space that they're in, may do need to require an additional signature, and they have existing systems to do that traditionally. Whether we add in the additional technology is TBD for capturing an actual signature, but to date, that hasn't been a requirement for any of our networks, to capture an actual signature form, unless it's a 42 program that already has a signature capture for that CBO. And in the former,
Before you go to the revocation, so does
Sure.
that mean that the community-based organization has to, who's actually recording the patient's or the client's consent? Is it the CBO internally, or is it somewhere in your system they're recording that?
they're recording the consent for the referral in our system.
Okay.
If that nonprofit wants to use other data that they have differently or in a different way outside of our terms, they have their own consent, electronic process separately if they need it.
So they're indicating somewhere in your system that they have gotten the client's consent to put their information in and share it, make the
That's
referral.
correct.
Okay,
That's
thanks.
Yep.
All right.
Yep. And for their revocation, they can revoke their private referral history from being viewable through that process we were showing earlier. If they want to remove all data, they contact our support team directly, but they still have that overall control.
And what about if they only worked with that one, like food pantry, let's say, and asked the food pantry to go ahead and make the referral to their, or the other way around, to their social worker to make the referral to the food pantry?
Mhm.
Can they talk directly with the social worker to ask them to do that for them so that they don't have to contact you directly? Or
There's a few ways that referral can be updated or amended. Traditionally, if they want everything removed from the system, there's regulation that I'm sure you're aware of. Some systems require 7 years of persistence of that data. So that would be a longer discussion, but there are ways that navigator can update what's appropriate to be seen. Contacting us is the best way to remove it from the system entirely.
Okay. I think we're past time. Are you guys okay? Well, no, I don't want to press this. So I think we're good. I do have one last question, which is if I wanted a peek at I know you said it was there's proprietary information. And we will certainly run anything we print about you by you before it goes to publication, that's for sure. But if I needed or wanted some detail in the writing from that PowerPoint, is that accessible or you'd rather not?
Let us know in a follow-up note what you'd like to see, and happy to share.
Okay. Yeah, and it would be, eyes only, and you would see it would just be for stats or for something specific that I didn't get the wording on or something
Sure.
of that order.
Yeah,